You do that. Lord, I need water today. All right, Jose, I'm going to read your bio first.
Sure.
All right. And are you, do you call yourself Kathleen?
You can call me Kathy. You
Okay.
have to say the
All
whole
right.
thing.
All right. Make sure because, some people get offended. It's like, Kathy. And I'm like, no, girl, my name is Kathleen. Sorry. Yeah, so I need to check in before I, you know, go on my happy way. All right, Harry, I'm ready. Here we go. Welcome to another edition of the show on 103.5 FM, WNHH, the New Haven Independence radio station. And this is the podcast called The Show. My name is Michelle Turner, and I have the good fortune of being its host. One of the things that I love about doing this show is that I get to call the shots, right? I get to invite my own guests. I do my own screening, I do my own vetting. If you're not ready to sit in the chair, then I'll invite you back for another time. If I think you're ready to sit in the chair, then we have the show. And I have the good fortune again of being its host for about the last going on 4 years, about 3.5 years now. And it is a pleasure to always get to talk about what I want to talk about. That I am not constrained by other forces or reason. And with that, I have been fascinated, absolutely fascinated, and I stand in wonder of the work being done against, and I can say the word against, HIV across the nation and globally. So, one of the things that I am fascinated with, because in all honesty, I have had very close friends and family members affected by HIV/AIDS. And so I've always been interested in what could get rid of it, a cure, or how people can live with it and live long and healthy and happy and respectable lives. And so when I heard about PrEP, I was very excited because it gives another option. And we'll get into the difference between ARC and PrEP somewhere in the conversation. But in the studio with me today are two folks who work out of the infectious diseases department at Hill Health, Cornell Scott Hill Health Center. And my good friend and soror, Dolores Greenlee, has entrusted me with two of the folks out of her department to come in today and talk about the disease. So, first of all, and PrEP. PrEP is the first part of this conversation. Everything else is going to come in afterward. So, thank you all for being here today. In the studio with me this evening, as we are broadcasting on Facebook Live, is David and Kathy. And I am going to give you their bios because I want you to understand that this work is not only intensive, but you really have to be in a space where you got some knowledge, you have some science, and that you are doing the work on a regular basis and dealing with the population who deals with the disease. So, Jose Gutierrez, MSN, NFP, BC, and y'all are going to have to explain those alphabets in a little while, is a nurse scientist and infectious disease provider interested in health disparities within HIV/AIDS and hepatitis C populations. It's focused on prevention, treatment, adherence, and harm reduction strategies. Born and raised in Galesburg, Illinois, as a first generation son to Mexican immigrants, Jose came to the East Coast to attend graduate school as a PhD student at Yale. where he's currently completing his third year of training. As an infectious disease specialist, he provides individualized care, utilizing evidence based standards, guidelines, and protocols to help patients achieve their health and wellness goals. And he got about 4 or 5 paragraphs after that, but we're not going to go that deep because I have to introduce Kathy, and that will take up half the show. So, Jose, I just want to say thank you and welcome.
Thank you. It's a pleasure to be here.
And Kathy is out of New York City, as she explained to me earlier, in South Carolina, where she's also done some work. And in all honesty, it's always fascinating to me that people who do your work travel, they go to different parts of the country and really do the research. And I find that fascinating too. Kathleen Pintner, MHA, MA, is the expanded testing coordinator at Cornell Scott Hill Health Center, where she provides HIV and hepatitis C education and point of care rapid testing. Ms. Pintner originates from New York, where she spent most of her career working and meeting the needs of underserved communities through policies and programs that reduce healthcare disparities. She's worked in the field of HIV care and prevention for over 15 years, and while in New York City and Georgia, she worked in community-based organizations focused on the disfranchised, those experiencing homelessness, HIV, and substance abuse. In South Carolina, she served as one of the state's regional operations managers overseeing HIV, STD-related investigations with local health departments, including partner services, treatment, and linkage to care. So, Kathleen, welcome to you, and thank you for coming in and spending your evening here. So, folks, how you doing?
Good. How are you doing?
Good. Get as close to that microphone as you can. Pull it up to you. Make it your friend. As I want folks to hear you. So, before we get into PrEP and its use and how it came about, can either one of you give me a little background on HIV/AIDS? What it is? Are we still not sure how or where it originated? And how much is this now considered a chronic disease as opposed to, I dare say, back in the 80s, an epidemic?
I think I can start off with saying that I can probably think of a few people that would probably be more qualified to talk about the history of the disease and their experience, particularly living through HIV through the 80s, seeing their families and friends going through this disease process in a very different way than how we might see some people go through the disease process today.
Mm-hmm.
I think a lot of us are at least generally somewhat aware that
Turn that with you.
Oh yeah, sorry about that. I think a lot of us are generally aware that it was a very scary time, particularly in the 80s when it was becoming more prevalent. People didn't know what it was, how people were getting it. It was a big stigma. It was a time of liberation, but also a time of fear because it was almost like a backlash to all of this sort of like liberation of just like sexuality and expression. And I think a lot of that past experience has kind of influenced how people see the disease today, at least with lingering stigma, what they think about people who get HIV, how it's transmitted, what it means to be on treatment, and what that means for transmission. I think there's a lot of information that needs to be given, I think, because the thing is things have changed. And that can be like seen in a positive and negative way. In a positive way, I think people are becoming more aware that, people with HIV are just like everybody else, they live long lives. Treatment is really great. It's like 1 pill a day for most people. I think people are generally aware now of how it's transmitted. We see lots of couples where one's positive, one's negative. I think that's all great. I think it also has lessened the perceived severity of how it's getting it. So I think sometimes people are a little bit more just like cavalier with like their actions, and just they might be a little bit less careful. I think now they see it as more of a chronic disease than it is, and it's great. I'm glad we've reached that point where people now understand that it's a chronic disease. But unfortunately, sometimes some people think that's associated with certain behaviors that have increased risk of transmission within certain groups.
And Kathleen or Kathy, um, there's a conversation that's being had about getting this information out to younger people because it seems at this stage, the younger people are now contracting HIV/AIDS a lot faster than the older populations. So, are we getting that information out to them? I mean, I know people my age and probably in your age group are very familiar, but it just seems that because it's growing so fast amongst young people, that maybe they're not getting all the information that we're putting out there.
I think that we've that generation, if we can remember our youth,
Get close.
which I'm sure we can. They have this idea of they'll live forever, and they don't really at times have the history that some of us have of HIV. So in the 80s, what it looked like, people were diagnosed 1 month and they were gone not too long
the
after
next
that,
month.
right? So people saw that, and now the kids today, they didn't see that. They don't have that point of reference. So for them, we're out there, we're educating them, we're talking about how, this is not a death sentence. Guess what?
Right.
It's chronic. You'll be okay. We don't want you to become infected, but
Right.
it is going to be okay. And so we talk about the new medications, and we talk about interventions that, if you are at a high risk, you can take these medications. And if you unfortunately do come and, and you are infected, there are medications to handle that. So to them, it may appear as it's okay. If I take it, if I get it, I just take a pill,
Right.
and I'll be fine.
Right.
And so it's trying to get them to understand, okay, it's not just that pill. Give an example.
It's behaviors.
It's behaviors. So even though when I meet people and we have to tell them, unfortunately, that they have HIV, I tell them that, yes, your health, this clinic, we have fine providers, you will do well. You'll survive and you'll live until you're old. However, I cannot prepare you for the stigma. I cannot prepare you for the first time that you find someone that you really are attracted to and you want to take it to the next level, the rejection that you will feel once you disclose your status. So just that.
Yeah, because I was telling people in my at work that this was the show that I was doing today. And, we had that exact conversation. So how do you end up telling someone, which was the point of 90 Days, the movie that you guys premiered a few months back. But how do you tell someone? And there's still a stigma of shame. There's still a stigma of secret, because some of my workers were saying, I wouldn't tell anybody. I'd be very discreet in who I would share that information with. But I don't know if I would ever have a sex life because I don't feel comfortable. And it was interesting to hear that from women who are younger than me, because I'm thinking like 90 Days. Well, you waited. Now you want to share this. You want to tell somebody, you want to tell your potential partner that this is what's going on with me and this is how we can have sex. And they were still like, no, rather not do that. I don't want to take a pill. I don't want to do this. And it's like, wow. So what would be your solution? I mean, to the people that are involved in this, I asked them, I said, what would be your solution? And they really were about keeping it a secret. And I thought that was interesting because in this day and age, ain't too much secret no more, right? We're on Facebook. People share their lives on Facebook and Instagram and, make comments on Twitter. Heck, even the president does it, right? So, how do you all, as practitioners, when you have to deliver that news, how do you get people to understand that while it is something private, like any other health malady, it's also something that you don't have to be ashamed of? Or does that come in time? Have you seen that with your customers, with your patients, that it comes in time?
I think it comes in time because when you first tell them, they're like, "I'm never having sex again,
Mm-hmm.
ever again in my life. Um, I just don't feel like it." And you pretty much say to them, at this point, yeah, I probably feel the same way you do.
Mm-hmm.
But as humans, we have the need for that connection. We
Right.
have the need for acceptance and love and intimacy. And unfortunately, you have the added burden of this disease that when you do enter a relationship, you don't want to just tell everyone, right? Because
Right.
the fear is, well, am I going to walk up to tell everyone I have it?
Right.
Well, no. If you're going out on a date, if it's someone you say, oh, I just hang out with him and or her and we go to the movies. But when you feel that this person is someone that you may want to think about being serious with,
Mm-hmm.
you will have to start doing some education and doing it maybe on the sly of like, well, tell me what do you know about
Mhm.
HIV?
Mhm.
Maybe introducing movies or something like that where you can kind of gauge where this person is at
Mhm.
before you disclose. And we do offer, our patients if they would like assistance and disclosing to family members, disclosing to partners. So we just let them know in the beginning and even, throughout their tenure with us, we're here for them. And it's not a
Mhm.
journey that they will go through by themselves.
And go alone. Yeah, because I think, like any other chronic disease, I think there's a period where folks do feel alone, like they're the only ones, and that, you can't tell me how I feel because this is happening to me. And so there's a lot of layers to that have to be kind of like peeled back
I
and
think
dialed
Kathy,
back.
I think Kathy hit on a really important part where, because Kathy and I have been together in the same room before when we've had to inform people that they were
Do you all
HIV
work
positive.
together?
Yeah,
Yes.
we do.
Okay,
Yeah,
so
we do.
y'all are partners.
Yeah.
All right.
I think that's one of the take-home messages when we do tell a patient that they're HIV positive is that
Mhm.
they're not alone. They don't have to go through any of this part of the experience alone. We can assist them with anything we can, especially when it comes to partner notification or perhaps they want to tell someone.
Yeah.
We always tell them, bring your partner in. Sometimes it's
Mhm.
easier to have that conversation with people who can answer some of the questions that they're inevitably
That they may
gonna
have.
you know.
Yeah.
And I think just like the messaging, I think is also going to be really important that we give to patients and just the community as well. So for example, one of the things that we're really pushing now is the phrase "you equals you," which means that if you're undetectable, you're untransmissible.
I
So
like
if a
that.
person, yeah, and I think it's like very effective, and hopefully it calms the fear of both patients and their partners or potential partners. And I'm hoping that becomes very commonplace knowledge where if a person who's HIV positive takes their medication appropriately and they become undetectable, which means that the machines that count the virus in the blood can't find the virus because
Mhm.
the medication has stopped the replication process so well that we can't find the virus when we try to count it. It's not a high enough viral load to make someone infected. So you can't transmit it to your partner. And I think that's going to be really important for the patient to really understand and internalize that, as well as their partners and just as well as the public. Because I think sometimes people, when they're positive and they're undetectable, they still think they can't have sex.
Right.
Or
Right.
they still think they can't like have a baby or something like that. Like
Right.
those are not all true whatsoever. Like they can still do everything that they wanted to do before.
Are there still a lot of myths you find surrounding HIV and AIDS?
I think so. I mean, like some people. I mean, I've heard some wild stuff before, but like
Yeah,
some
I'm
people,
sure.
like, yeah, I think just like when it comes to like transmission,
Mm-hmm.
just like how can people get it? Like through kissing? Can they get it through, sharing like plates and forks
Right.
and stuff like that? I think I think some people are scared because they think like, well, what if there's like a 0.0% chance that if we kiss and I get HIV? It's like no, it's like that's not a thing. Like and I think it's important to just tell anyone, like look up the craziest things you find on the internet
Mm-hmm.
and bring them
Right.
here and we'll just talk about
And
it.
we'll
It doesn't
talk about
matter
it. That's
how,
a good
like,
idea.
insane
Yeah.
it is. Because
Right.
people like look up stuff on the internet all the time, and I think that's great. Find out all the crazy stuff that you can find, and then let's just have a conversation about it. And let's kind of suss out what's true and what's not really true.
Child, unless you go on WebMD, because I've been on WebMD to look up stuff for myself, and I'm like, oh, I gotta make a doctor's appointment
You
because
have
something is
everything.
definitely wrong with me.
Mhm.
And then I go to the doctor, and he's like, Michelle, really? Oh my God, You, more than anybody else, should know. You can't trust everything you read online. I said, but it's WebMD. He said, exactly. WebMD. So not to be on WebMD's case, but I just find that the information that I look for usually scares the daylights out of me.
Right.
So I can imagine somebody coming in with a diagnosis and having questions.
Yeah, of course.
Yeah, I'm sure.
Which is natural.
Yeah.
The unknown makes you want to like soak up
Right.
information, and I think it's natural to kind of let your mind wander, especially if you're not really sure.
Yeah,
Right.
of
what's
what
just
you're
happened to you,
facing.
or- yeah.
Yeah. So let's talk about PrEP.
Yes.
I am excited about PrEP as a layperson just for the simple fact that it's preventative.
Right.
And it can save a lot of lives. So what does that stand for? What does PrEP, P-R-E-P, stand for?
So PrEP means it's an acronym for pre-exposure prophylaxis. So it's kind of similar. It's kind of a similar acronym to PEP, which is what some people might receive if they've ever, particularly people in the healthcare industry, if they've ever got a needle stick or something like that.
okay.
They might give them this medication called post-exposure prophylaxis. And basically, both of these things, especially, but in particular PrEP, they're antiretroviral medications that we've already used with people who have HIV.
Now explain what
yeah.
the viral is.
Yeah, of course. So basically, just like really short, HIV is a virus that affects the cells that make up our immune system.
Mm-hmm.
And the way that happens, that there's like a process that has to happen. It uses different components of the cell to make more of itself, which go out into the rest of your body to infect more cells. And then it reaches a point where it can reach a point where it uses up all of your cells, your CD4 cells, your T cells, to the point where your body can no longer fight off infections. Your immune system is down.
Get
and
closer.
Then that's what's considered AIDS. Okay, it's a little bit more complicated.
Yeah,
than that,
complicated,
but that's a quick and dirty.
Yeah.
That I'm sure like some people will call me up later and say like you need to go more in depth in that. But, like let's just
Then they
start
can
there.
talk to
Yeah.
you.
Google it. All right, go to MD and we'll just talk about it. But essentially what these medications do is the antiretrovirals, they essentially stop the replication process
Mm-hmm.
of the virus, and they stop it at different points. So most antiretrovirals for people with HIV are composed of like about 3 drugs, and they work together to stop the drug in its tracks, and that's how a person becomes undetectable. The virus no longer replicates, so people no longer have a detectable viral load. What they found out was if they use 2 of the drugs, particularly tenofovir and emtricitabine, which make up the drug Truvada,
Okay.
they find out that if a person takes it before they get exposed to HIV, the drug accumulates in certain areas of tissue, like the rectum or the vagina. So when the virus gets exposed to that location, the medication stops the replication process from even establishing an infection.
Immediately.
Yeah. So that's how it's like a pre-exposure. So you take it before the exposure, and it helps protect you against getting an infection of HIV.
So if somebody starts on the medication,
Right.
how soon is it effective? I mean, I know
Right.
it goes through the bloodstream, it takes hours, but
Right.
when could somebody
Mhm.
actually say, okay, I feel comfortable enough that I can go ahead on and
Right.
have sex with my partner?
That's where it gets kind of dicey because different people might say different things. The
Mhm.
guidelines usually we say, please be on this medication for about 20 days, 21 days before you start having, the kind of sex that might put you or
At
kind of
risk.
at risk for getting HIV. There's some studies that look at on-demand dosing, whereas you take 2 pills, maybe about the day before you have the exposure, then a pill, like 2 or 3, 4 days after that. And that's been somewhat effective,
Mhm.
impressively effective, I would say. So the time that it takes for a protection level is still not completely clear, but if you want to be safe, generally I would say like I would go with the guidelines for now and just say about 20 days. But
20
I think
days.
there's like some evidence that shows that you could be protected with a little bit less than that.
Okay.
Yeah.
All right. So, Kathy, who should consider taking PrEP? Like, what's the population?
So I will say before I answer that, when PrEP was initiated in the beginnings,
Mhm.
the manufacturer did not do the best job at marketing.
Absolutely.
So they
it was
really
very
focused-
controversial.
Yes, they really focused on white gay males.
Right.
And they kind of, when you saw the marketing materials, it was like, oh, so it's not for Black
Yep.
women who have high rates. In Connecticut over the last 4 years, we've gone up 57% increase in HIV infection.
Mm-hmm.
So, and it wasn't geared towards really, I mean, if you're a gay male, Latino or Hispanic or African American, yeah, you may have felt like, okay, I guess I can take it. But it really did not do its job.
Speak to the community.
Correct. But generally, people who we see and we screen for eligibility are generally individuals who are at high risk for HIV. So individuals whose partners are HIV positive, individuals who are probably, they have high, they have multiple partners and they're not protecting themselves when they're having sex. Someone who's probably IV drug user, someone who's probably selling sex for drugs or money. So anyone who's
sex worker.
Yeah. So anyone who is their level of coming in contact with HIV is high, then those are the individuals that we're looking to encourage to be on PrEP.
And I was surprised at folks with injections who are using needles. I was surprised that they would be recommended for this drug because I'm thinking about sex. I'm not thinking in terms of needle use, because to me, and in this town, by us being one of the very first in the country to do the needle exchange, I don't think that often about people getting HIV and AIDS from drug use, but it is very much a part of this, and it's very real.
And among the intravenous drug users, those numbers have come down, or they've been steady. And we've done a great job, because when we think about harm reduction, where did harm reduction come from? It came from us in the beginning talking about how HIV was transmitted in the beginning, and encouraging people to not share needles and do harm reduction methods. But these individuals are still at risk because they share needles, and if you share a needle with someone who's positive, and you don't clean that needle, then you are at risk for developing HIV.
And it's interesting too, because now you have all of these lush commercials, right, for PrEP, and the people are brown and they're black and and they're male and they're female, and I'm like, oh, this is really cool. Somebody knocked you guys upside the head and said no. These marketing materials, as you said earlier, are not getting to a real community that needs it. And so now, I see these commercials during soap operas and basketball games and on HGTV. I'm like, all right, now somebody has gotten to you all. So it's, at least in that spectrum, I see it, and it is getting out. So those people who don't have HIV but are at high risk of becoming infected are the ones, as you just said, who take PrEP. But in the case of folks who inject drugs, say over the past 6 months, they also should be taking PrEP, right? Because it's one of those things where, as you said, they're sharing needles, they're sharing their works. They haven't been or have been in drug treatment. So this is another way to lessen their risk of infection. And it says, what I read today, 90% of folks having sex it's effective in 90% of folks having sex. And it's 70% effective with injected drug use. So those are great numbers, right?
Right.
Yes.
And some studies will say, even with so right now it's a daily dosing. If you take the medication every single day, it's up to between like 92 to 99% effective against preventing HIV. And pretty much there's thousands and thousands of people on PrEP, and we've only had maybe about just like a handful of what they call PrEP failures. And that's considered where a person was adherent to the PrEP and then they got HIV. And there's different reasons why they think that
I was
happened
gonna
in
say
those, like, 6
there
or
has to
7
be
or 8
different
people,
reasons, right?
but that still doesn't change, like, just how, like, literally tens of thousands of people are currently on PrEP, and they're taking it, like, fine without any
Right.
without any seroconversion to become HIV positive, which I think is absolutely great.
Yeah.
And I did want to touch on a point that I do like that they're doing, like, more commercials with, like, more brown people.
Yes.
Mhm.
They did like a study where they looked at people who fill prescriptions for PrEP,
Mm-hmm.
and they find out that it's typically like Caucasian, older, white, educated men, and that's great. I'm glad that they're
Right.
getting PrEP, because we're all for people getting PrEP, to
Right.
protect themselves,
And taking care of themselves and
Yeah.
living. Yes.
but it's not the demographic that's most at risk for it. So
Mhm.
I don't know if it's a messaging problem or if it's an access problem or if there's, like, a barriers problem, but, like, I definitely think that it is important to kind of, like, sort of, like, begin to look at our focus towards this, sort of marginalized group that might be most at risk for getting infection, and they're
Mhm.
not the ones filling scripts for PrEP. So
Right.
I do think maybe it's part of a messaging thing through marketing. I know there's studies going on right now that look at that specifically, but I'm happy that we have now people that are specifically addressing that part, because that is something I think is a
Yeah,
severe
because
gap.
because for so long, well, not so long, but I know as far as the length of the life of this pill, as you all have stated and we, made plain that basically this drug was not, I don't want to say catered to, but introduced on a broad level to folks of color.
Mhm.
And so now at least we're beginning to see the commercials,
Mhm.
and you learn how to pronounce the name of the drug, and and they show you who it's for, and they show all these happy people going about their lives,
Mhm.
because one of the statements that a coworker made to me today was that if you're HIV positive in this day and age, you don't have to look it. There was a time when folks looked sick.
Mhm.
And they called it the sickness. And one week you were here, and then you started to look very sick, and then within 2 to 3 weeks, you were gone.
Mhm.
And so now, when you see these commercials, I think it is a reminder that, okay, I look healthy,
Mhm.
or I am somebody who is having sex with folks who are at risk or at a high risk, but I'm a healthy looking person.
Mhm.
I'm not whatever this image is that you have of me. I'm not that.
Mhm.
And yet and still, I am reaching out to be protected. And I'm trying to let other people know that it's okay to be protected and to get this medicine and use it.
Mhm.
Because the other thing in the Black community, specifically, when I was a young woman, was that there was a whole myth around taking meds, and whether they were placebos and whether we were being experimented on.
Mhm.
And it was legitimate based on the Tuskegee study
Mhm.
and then Henrietta Lacks. So, people had a real issue with, okay, first you didn't want to treat me.
Mhm.
Now all of a sudden you want to treat me. Well, what's going on with what you're giving me?
Mhm.
Am I being experimented on? Or is this something that is really going to take care of me?
Right.
So I think when you see commercials, and not to say that television legitimizes everything,
Mhm.
but there's a certain amount of, okay, well, maybe it's something I should look into.
Mhm.
It kind of gives a different type of story, if you will.
And also, there is unfortunately some stigma around taking PrEP.
Mm.
Some people don't, when their family members find out that they're taking PrEP,
Mm-hmm.
they are seen as promiscuous.
Mhm.
And so that is a hindrance as well, trying to get people to say, okay, no, it's okay. Tell them I'm taking it because I don't want to become infected.
Right.
But there's
Mhm.
something, that we also have to think about when we're trying to educate the community about PrEP.
Yeah, because I think in so many instances, when we talk about this disease, there's been so many myths around it. And there's so many myths about care
Mhm.
and what really works and what doesn't work. I think that people are skeptical.
Yeah. I can even use, like, myself as as an example. I'm not sure
Mm-hmm.
how generalizable my experience is to anyone else, but I think I'd known about. I'm currently on PrEP, but I had known about
Mm-hmm.
PrEP since maybe 2014,
Mm-hmm.
and I think I had just now gotten it for about maybe a year and a half. So there was like some time where I knew about PrEP, I knew what it could do, I knew how to get it,
Mm-hmm.
but there was this barrier of sort of having the conversation with the provider, like having to disclose this part about myself, like answer questions that might be
Yeah.
embarrassing. I mean, I had known that I was HIV negative, but like, what if like, just going through STD testing is stressful all over again? What if
Right.
I have something like, it's like kind of sort of coming face to face. I mean, like even old ways of protecting myself, like
Mm-hmm.
using condoms, like there's a anxiety that was associated with that, like, oh,
Right.
are condoms always safe? Like, did, something happen?
And
But
people still don't use condoms properly.
yeah,
You
yeah,
know, no matter how many
Mhm.
times. I mean, you could go to YouTube and look up
right.
how to use a
Yeah.
condom, right?
But after so many years, even that anxiety was familiar. Like
Yeah.
I was familiar with that anxiety of like
Yeah.
just using condoms and like suddenly trusting this pill to sort of do the same thing that I had sort of
Yeah.
like trusted condoms to do for such a long time was like a big step. And I think it was like sort of a barrier to kind of, decide to go this route, So I think just like using my own experience, I think there's definitely a big sort of jump you have to make to actually initiate PrEP. So I mean, it's a lot of conversations with a lot of people you've never met that might be
Mm-hmm.
kind of embarrassing. Everyone might not be about that.
And it's like anything else, it's moving out of your comfort zone.
Yeah.
Like you said, for so long you're used to using condoms, and now all of a sudden, now I'm going to take this pill. Well, is it going to have the same type
Yeah, you're
of
trusting
protection?
science, right?
Right.
And that's
And
kind of scary for some people,
yeah.
especially as you said, if you're part of a community that didn't have like the greatest experience with science and
Mhm.
medicine and
Right.
experiments. So yeah, I can totally understand why that would
Mhm.
be a hesitation for sure. Yeah.
So if I think that I am a person, like you just gave the example of yourself, David, if I think I'm a person who is ready to use PrEP, what would be my next step?
Well, I guess sorry. I don't mean to laugh. Sorry, you called me David twice. It was just so funny.
Did I call you David? And it's Jose.
okay. No, it's all right.
Because you look like a David to me.
I hope that David's very handsome.
And
has
you
a
know
less-
what? And
has
he's
less
a
raspy
nice
voice
guy.
than I do.
And he's a nice guy. So forgive this old
No,
lady.
no worries, no worries.
Oh
It's
my
just
gosh, I'm
funny.
so
I
embarrassed.
wasn't able to
They
like,
got
answer
me
that
on
question with, like, a
air
straight
calling
face.
the person the wrong
Anyway.
name.
But,
Why don't you just tell me? Gosh.
I would say definitely the first step
David.
I think the first step, honestly, is so it might be hard for some people just to jump to a healthcare professional, right?
Mhm.
Honestly, I think the first step is just kind of like, read up on what you like can find on the internet. There's a few really great websites that like have a lot of like really easy to digest information.
Mhm.
Talk to your friends that are on it, see what their experiences are like. See what to expect in a visit. Maybe it's not as scary as you thought it might be,
Mhm.
or as invasive as you thought it might be. But at some point, just like I would suggest just making the visit sort of just like a general health visit. We all need an annual physical. Just say
Right.
you want to go for an annual physical, and then just kind of mention it. I'm thinking about PrEP. And also know that not all providers are as familiar with PrEP. So just also know that that might happen. They might not know what that is.
Well, you
and
can go
sort
to
of, like-
Cornell Scott Hill Health Center and
That's
find
right.
out.
Yes.
That is right. But just also like sort of like arm yourself with knowledge just in case the people you talk to aren't so prepared with information. So that way
Mhm.
you can ask them how you can get navigated to the correct place.
Yeah.
Yeah.
Because that's important. So what's the difference between ART and PrEP?
So basically, ART stands for ART, which is antiretroviral therapy. So basically, there isn't much of a difference between ART and PrEP when it comes to the medication, except that ART typically has more medications than PrEP does. So PrEP currently is composed of 2 medications, whereas ART therapy typically might have more. ART therapy is used for people who have HIV to stop the replication process of increasing the viral load within them. So typically we would say that for a person to be undetectable and to remain virally suppressed, they are required to take ART every single day for that to happen.
Mhm.
Whereas a person who is on PrEP isn't necessarily, they don't have to stay on PrEP for the rest of their lives. They can stop whenever they want. They can, if they decide that PrEP isn't something they want to do anymore. Like they can just, they don't need it to become.
And they're
virally
not
suppressed.
necessarily HIV positive, right?
Right. And I think that's also important to know that if you take HIV medications, it doesn't mean you're going to get HIV. Like that was one of the questions that I was asked, and I think it's a
It
legitimate
is. It's a
question,
legitimate
you know?
question.
Like if I take this medication, does that mean I'm going to get HIV if I stop, or if I just like
Mhm.
it doesn't happen magically if you just take the pill. It isn't one of those things where if you stop taking the medication, somehow the virus you're gonna get HIV positive. It protects you from getting HIV though. That's the thing. Like as long as you're on
And that's
it,
what you.
you're
That's
protected
yeah.
against
And
it,
that's what you want. Yeah. Yeah. So it's not a vaccine. You don't get it. You only get it in pill form, right?
Right. And I'm sorry for like keeping like answering all these questions, but like that's the part I get really excited about though, just because there's like a lot of really cool research coming down the pipeline as far as PrEP is concerned. So they're currently trialing. Oh, sorry. So they're currently trialing injections that are extremely promising. So essentially, it'd be an injection you would get about like every 8 weeks or so, and it wouldn't be a daily pill, which is absolutely amazing. Right. And I think that's probably going to be like, a thing to look out for, in the future. So right now,
is it close future or is it like 7 years future?
Oh man, I don't know. I think I think I'd have to look at which phase of the study it's in, but I want to say within the next few years. Don't quote me on this, anyone listening, but like,
no, we're not going to make you responsible for the information.
And I think I also want to like talk about some people talk about like side effects or safety profiles of the medication. So Truvada has a tenofovir. That's a medication that's used in typically somewhat older medications that we use for art therapy. Some people might think that it affects the kidneys and bones. I think it's one of those things where we're going to move away from Truvada within the next year or so. So I don't think that's something that we're going to really have to worry much about. We're probably going to move to something of a newer version of tenofovir that's going to be easier on the kidneys and bones. So if anyone has any hesitations about like using this medication because they might have heard something that it's like a negative side effect, I would say I don't think you're going to be on it for very much longer. So I think we're going to be moving to a medication with a good safety profile.
So are you all going out into the community, spreading the word? Are you going to churches? Are you going to barbershops? How are you hitting the public about PrEP?
So we, Jose, I want to call you.
Now you want to call him David, right? So are you Jose David now?
I kind of like David now.
Jose.
Didi's going to get me for this.
He actually, came with this wonderful idea. We do a lot of outreach in the community. We go to universities, we do testing, we talk about PrEP. We've had a Kiki ball.
A what ball?
A Kiki ball.
What's that?
So
I didn't get an invitation. What's up?
So I wish that someone else was here to really explain it well. But it's an LGBT ball. It's like a dance ball. And that was held, I do believe it was held in November 17th. And the individuals were educated on PrEP. But
it's like voguing too, right? Yeah. It's like Kiki balls are typically like
voguing.
There's
dance.
like houses and they kind of like perform voguing and stuff like that. It's like I feel like it's pretty big in New York City.
Yes.
If you look up like Ball House, there's like different houses and stuff like that. But anyway, we have like a mini one here in New Haven, which I thought was really neat.
So. Yeah, that's cool.
Also, we have PrEP night. Right. So Jose has like really spearheaded that. We have these T-shirts. They're black T-shirts with PrEP on it. And we go to the different bars. Generally they're the gay bars and like Gotham. And we go out and we do education, we offer testing, but really just kind of, just pretty much ask me about PrEP and getting people to say, what is that? And going where people are. At times I think
meeting
providers,
them where they are.
Right. Have this thing where, okay, brick and mortar, I will build it and they will come.
Right.
And it's like, no, people generally don't do that.
Exactly.
So I thought this is a great idea. We went out a couple of nights. So we're doing a lot of outreach in the community and trying to develop and establish like new relationships with people, different organizations, to figure out what is the best way. What are the
And
best
how are you being
avenues.
received when you go someplace like Gotham, which is a club, and people are in a different mindset,
Right.
and here you come talking about, well, let me tell you about prep.
You know what? When the
Mm.
times that I've gone out, they have been very receptive, and some have educated me.
Ah.
So it's not something where people are running and scurrying away from you,
Uh-huh.
but
Mhm.
they're very engaged. And I've met a lot of people that were informed and that were on prep.
Mm.
So
Yeah, and it's great to hear people's experience,
Right.
especially if they're on prep. They're like, yeah, I'm on prep, or like, oh, I've heard of it, and you
Yeah.
know, like sometimes it's just like an access issue, like they've heard of it, but they don't know how to get on it, or they think because they don't have insurance that they can't get on it, which is not true. They don't know how to pay for it. But I think it's like really illuminating, just kind of also just hear the feedback from
Mhm.
people. You know, I don't think anybody was like, I don't think anyone had a problem with it. Actually,
No.
I think people were kind of like cool, like they thought it was kind of neat. You know,
Mm.
so I mean, I think it's pretty neat.
So it's a risk reduction tool.
Right.
That's what it's considered.
Right.
And it's been effective.
Right. Very effective.
yes.
So my question is more or less on a recommendation.
Right.
Because when you're talking about dealing with folks who are in that high risk group, but not necessarily HIV positive, or, they have AIDS, is it difficult to have that conversation with someone? Are people, because, again, in thinking of in terms of how receptive folks are people, saying, well, I don't have it, so why should I take it? Do you run into that a lot?
I want to say not. Well, sometimes. I want to say sometimes.
But not heavy.
No, not heavy. I think so.
Mm.
Well, because there's also a little bit of a commitment that comes to
Mhm.
being on prep. So when you're on prep, you typically have to come in for a visit every 3 months,
Mm-hmm.
where you get tested for HIV, because you can't have HIV and be on just Truvada. You have to be on
Okay.
a different like sort of cocktail.
Okay.
So that's why we have to test people every 3 months just to make sure they don't have HIV. And then we also do STD testing. And for
Mhm.
some people, they don't want to come to a clinic every 3 months.
Right.
So sometimes we have people that start off of it and we just lose them the follow up, because it's kind of time consuming for them. They don't go to the get seen already, and now you're expecting them to come every 3 months is kind of a lot to
Yeah.
ask for them.
Yeah, and because in some ways you're dealing with folks who really aren't familiar with going to the doctor on a regular
Yeah.
basis.
Mhm.
Mhm.
They didn't grow up having annual physicals or
Yeah.
visiting a dentist
Right.
or those sort of things. And so you have a population who is skeptical.
Right.
Right?
But I will say though that the coolest thing though that I've also heard from patients about being on prep is like they feel like they always know their status.
Mhm.
And
Yeah.
a couple have mentioned how they almost are relieved when a partner they are with is also on prep, because that person's also going to know their status. They're going to know their
Mhm.
STD status,
Mhm.
their HIV status,
Mhm.
and it's not going to be some random person who hasn't been to a clinic in forever and might not know, if they like have gonorrhea or chlamydia or something
Right.
like that.
Right.
So I think some people have comfort in knowing that they do get seen all the time. I think that first visit is tough. Speaking for
Yeah.
myself,
Mhm.
Yeah.
a lot of questions, unfamiliar. But then after that, it's not a big deal. It's like, I don't know. It's just like not a big deal to go in every 3 months.
Yeah.
To be
And
honest.
yeah, because like you said, you want to know your status.
Yeah.
So if
I mean,
you want to
even if
know
you're
your
not,
status, you're
even if you're
gonna.
not sexually active, it's just kind of like it's nice to like go in and get in like seen and
Mhm.
I don't know. I'm kind of a hypochondriac, sometimes, so it's like, but also I have this cough, so I'm just kidding.
And by the way,
Hey.
so what do you want people to know about this drug? What do you want them to know, the population that you deal with? If somebody were listening right now, what is it that you want them to take in from the information that you all have given?
I would want them to know that it is an effective tool. It's another tool to add, intervention to add to your toolbox. You
Mhm.
use condoms, you know your status. It's nothing to be afraid of. It's nothing to stigmatize. Yes, there is a commitment, but we have individuals at our clinic,
Mm-hmm.
like a prep navigator that will walk you through that process and send you reminders and encourage you to continue taking it. And at some point, if you feel like you're not at high risk in some point in time, then okay, you will help and coach you to get off prep. But I think it's a very effective tool,
Mm-hmm.
and um, it's worth your it's worth your health. It's worth
Mm-hmm.
you knowing about it, and if you are at high risk, to finding a provider to help you get onto prep.
Mhm.
And
Oh, I totally agree with Kathy.
Mhm.
Like, it's just another method you can do to help you know empower yourself and enjoy yourself as a human being. I mean, like, we're all
Mhm.
humans, we're all sexual
Right.
mm-hmm.
beings.
Mm-hmm.
I think we should be able to you know express ourselves sexually, however, whatever floats
Right.
your
Mhm.
boat, but also protect yourself along the way.
Right.
And this is just one of those things. It's not prep isn't for everybody.
Mhm.
But if you're curious about it, I mean, I think it's definitely worth the
Yeah.
conversation to see if it might be something that might be appropriate for your lifestyle. Some people get reduction in anxiety, before they
Right.
would never be able to enjoy the kind of sex that they wanted because they were sort of afraid um, of a potential like HIV infection. And for some people, this is sort of like liberated that feeling for
Yeah.
them. And yeah,
Mhm.
I think it's totally worth the conversation at least to see if it's something that might fit in your lifestyle for you.
And I'm going to back up here a little bit.
Yeah, of course.
I should have asked the question prior. Um, but how many people are on your team? Like, and who does what? Or does it change? Like,
Right.
One night you might do something and you take on that responsibility. The next night,
Mhm.
kind of swap out. How many people are on your team, and how do you rotate different things based on experience, based on background? How's that work?
So we have four providers. So
Great.
three. Okay. So there's Dr. Barnes, who's our
Mhm.
medical director,
Mm-hmm.
Dr. Mon, and Jose, who are
Mhm.
our infectious disease providers.
Mm-hmm.
Then we have medical case managers, and we have about four medical case managers, I believe, but they are HIV care specific. So
Okay.
for those individuals that are infected, they provide supportive services too. Then you have myself, who is the ETI program coordinator, and
And what does that
um,
stand for,
and that's the
ETI?
Expanded Testing Initiative. It's a
Okay.
CDC, Centers for Disease Control grant,
Mm-hmm.
and that's really focused on HIV prevention. So within the clinic, um,
And
our
our
roles
fabulous
vary.
MAs too, by the way. Our
Yes,
medical
and we do.
assistants
I'm
are
sorry,
great,
we have two fabulous MAs
and a
that
wonderful
hold the team
nurse.
together,
Yes.
and an infectious disease nurse. So everyone works together just as a team.
Mhm.
When a patient comes in, if they want a rapid test, I'm there to provide that test.
Now, what is that?
A rapid test is a point of care test. So it's a hepatitis C test or an
Mm-hmm.
HIV test.
Okay.
And there are two HIV tests that we use. One is an OraQuick. It was an antibody test, and an Alere fourth generation, which is an antigen and an antibody test. And the difference is that one test only looks at your body's reaction to a
Mm-hmm.
possible HIV infection,
Mm-hmm.
and the other looks for the possible virus of
Antibodies. Yeah.
HIV as well as your body's
Okay.
reaction to that. And so, doing the testing, providing other care, we deal with not just HIV and hepatitis C,
Mm-hmm.
there are other things that
Infectious
we do.
diseases that
Right.
you deal with.
So,
Yeah.
I mean, we have a great team, and it's growing. So sometimes I do forget. I'm sorry.
Right, and that's also really important that rapid testing, like, we also do that. I think
Mhm.
most clinics do that, but like
Mhm.
if people want to know if they have HIV today,
Mm-hmm.
or at least have like a I mean, we can't ever confirm a diagnosis with a rapid test,
Right.
but I mean, it's if someone wants to kind of know if they think they might be like have an infection, they can always come in for a rapid test, and those are free, I think.
Correct.
Yeah,
We
those are
don't
free.
charge for those. Those are
Okay.
free. That's
Mhm.
funded through the CDC, through the state.
Okay.
Yeah.
Mhm.
All right. So you Jose mentioned something about they may not know right away, even though it's a
Right.
rapid test.
Right. So as Kathy mentioned, the test tests for your body's reaction to an infection potentially.
Right.
And sometimes there's like a window period where you might have the virus, but the body hasn't made the appropriate response
Mm-hmm.
to be captured on the test. So there's other ways that we can do that, but that's not as rapid. So but sometimes typically like some people are still comfortable with knowing that sort of like result right then and there. And if they want like a more in-depth like sort of workup, we can provide that.
Mm-hmm.
Am I kind of correct on that? Or
Yeah,
Okay.
yeah.
All right.
So we just let people know that how I explain it is the rapid test. If it's reactive, we don't
Mhm.
say positive. If it's
Mhm.
reactive, it does not mean that you have HIV. And how I explain the test to them, it's a screening tool. So it's meant to be very sensitive so it catches everything. And sometimes I give the analogy of if you're a fisherman and you cast a net and your intention is to get catfish, but
Mhm.
when you pull the net in, you have mackerel and tuna. And so that test sometimes will react, but then when we draw your blood and we send it to the lab, it tells us no, that person is not infected with HIV. So that's why we let people know if this test reacts, do not panic. We have to draw your blood and send it to lab, and then they have the specific
That's
tool
the next step.
to
Yeah.
look for HIV.
All right. Wonderful.
Mm.
I've learned a lot. I've learned Jose's name.
Some people still haven't, so don't feel bad.
Yeah, but
I think he'll be AKA.
My mom,
for
still
a
calls me
while.
my mom still calls me my sister's name once in a while. I don't know if that happens to anyone else.
Yeah.
But
It does. Your every other sibling until they get your name.
Yeah, right. My grandma Turner used to say "you child," and everybody would turn around. So we didn't even have names. Kathleen Pittner, Jose Gutierrez, thank you so much for this.
No, thanks
I
for
really
having us.
appreciate it. I've learned a lot, and you've given out some fine information. So give me clinic hours. Tell me when folks can come in and see you.
Pretty much. So we have several locations. We're on State Street. We're on Columbus Avenue.
Mhm.
We have
Dixwell,
Dixwell.
Wellmont.
Yeah. And we're kind of everywhere.
Yeah.
And there are different times, but I think we have different times that work for pretty much
For
anyone.
for
Mhm.
everybody.
Anytime between 9 to 5,
Mhm.
you can typically find one of us. And all the providers are really great. You know, non-judgmental. You can literally tell them anything. We've heard it all,
Right.
and there's no judgment, which is like I really enjoy that about my colleagues.
Yeah.
And we do have
Important.
extended hours. So on every first and third Tuesday,
Mhm.
we have something called Talk About It Tuesday, where the health center at Dixwell site and Columbus site offer after hours testing. So we
Okay.
extend those hours for individuals that are working
Mhm.
or, they have children and they can't come between
Right
8:30
away.
and 5.
Yeah.
So to know that during, the first and third Tuesday. Also, if you call me and you say,
Mhm.
Kathy, it may not be the first and third Tuesday, but if you say, I really would like to have a test and it's going to be after 5,
Mhm.
the Columbus site where I'm normally stationed will stay open until I do believe until 7:45. And then I can accommodate that as well.
And we do have, LGBT care is provided by all of our providers within the whole entire organization, but
Mhm.
we do have a very LGBT supportive clinic on State Street on Monday in case anyone wants to come in with like
Great.
specific questions about trans health or like
Yes.
specific to LGBT care. Like we have that clinic on Mondays too.
And what's the main phone number?
So
203
203
503
Yeah.
3000.
3000. Yeah.
I was
That's
like, gonna put out my
it.
own number.
Well, can people reach you both at that number or?
Yes.
Yes.
Okay.
Yes.
All they have to do is ask for you, right?
Yeah.
Yes. And I actually do have no, I don't have a card. I have another number on it.
It's okay. Jose Gutierrez, MSN, FNP, BC, is a nurse scientist and infectious diseases provider interested in health disparities within HIV, AIDS, and hepatitis C populations. And Kathleen Pittner, Am I pronouncing that correctly?
Yes, Hittner.
Okay. Is MHA is the expanded testing coordinator at Cornell Scott Hill Health Center, where she provides HIV and hepatitis C education and point of care rapid testing. Thank you both so much for coming in today.
Thanks for having
I
us.
appreciate
you.
your
It was a lot of fun.
time.
Yes,
I
thank
appreciate
you.
the conversation. And hopefully, when it turns into a vaccine, y'all will come back.
Yeah.
Yes.
All right. Thank you, Dolores Greenlee, for these two wonderful folks that you have. Thanks to all the folks at Cornell Scott Hill Health Center. Thank Harry. Yay, Harry. Because without Harry, we can't get it done. And this has been the show on 103.5 FM WNHH. Oh, you know what? In all this time I've been sitting here talking, I didn't do the legal. You're listening to the show on 103.5 FM WNHHLP, broadcasting live from downtown New Haven. We are streaming live on TuneIn Radio and newhavenindependent.org. We're also streaming live on Facebook. Just go to facebook.com/New Haven Independent, or just go to your Facebook page and look us up. Again, thank you. Thank you for listening to the show. And Harry, you're the best. Yay!
Yay!
You done?
Thank you.
That was
you were great. You
fun. I
made me
know,
feel
you were so
comfortable.
great.
Oh,
I was like so
good.
nervous. I was like,
I was like, oh my gosh, she's
David?
gonna ask us, I'm gonna be humming the whole time.
I thought it was so hilarious. But I just didn't say anything, but then I had to talk, and I was like laughing, like erupting, because Kathleen and I were just like looking at each other. I'm like, I can't look at Kathy and talk. And then I did, and I just started laughing.
Oh my gosh, I'm so sorry.
Don't worry
And
about
I'm
it.
usually, and I'm usually
Don't even worry about it.
conscientious of that.
Don't worry
'cause,
about it.
You know, my daughter has a very short name. Her name is Mia.
Uh huh.
And people